Welcome, future nurses, to the deep dive. We're often so focused on the miracle of birth, that incredible transformative moment. But what happens after? What about that crucial, often overlooked period known as the fourth trimester? It's a whirlwind of rapid change, both physical and emotional, for new parents. And it's where you, as BSN nursing students, are about to become their most vital guides.
Exactly. Yeah, today we're embarking on a critical deep dive into postpartum nursing care. Our mission really is to distill the most impactful nuggets of knowledge. So, understanding the complex physiological and psychosocial adaptations, arming you with the absolutely essential assessment skills, and highlighting the interventions that truly make a difference in supporting clients and families during this transformative time. We've pulled together a rich stack of sources that offer a comprehensive roadmap to this incredibly important phase of nursing, tailored specifically for your journey as BSN students.
Right. So whether you're prepping for your clinicals, tackling an exam, or just, insatiably curious about this vital period, we're going to unpack the what, the why, and most importantly, the how of caring for postpartum clients. Expect those aha moments as we connect the dots, offering practical insights and hopefully memorable details that will stick with you long after this deep dive is over. It's really about giving you the tools to be confident and make a real impact.
Absolutely. By the end of this deep dive, you'll have a systematic approach to postpartum care, a deeper understanding of expected findings versus the red flags of potential complications, and an appreciation for the holistic support families desperately need. It's about building confidence and ensuring safety, preparing you for real-world scenarios in your nursing practice, scenarios where every assessment and every interaction truly counts.
Okay, let's unpack this term, the fourth trimester, or puerperium. Sound like a continuation of pregnancy almost, but also a very distinct phase of its own. What exactly are we talking about here, and why is this understanding so fundamental for nurses?
That's a great way to think about it. The postpartum period, or puerperium, is typically defined as the first 6 weeks after childbirth. Though some sources, and for good reason, extend that out to 12 weeks. The most critical insight here for you as nurses is that this isn't just a recovery period, it's a phase of intense, rapid transformation. The body is adapting from a pregnant to a non-pregnant state, while simultaneously, families are adjusting to the immense shift of integrating a newborn into their lives. So understanding this dual physiological and psychosocial journey is, well, it's paramount to providing holistic care.
Yeah, and our sources point out that not all changes are about returning to how things were before pregnancy. There are these retrogressive changes, but also progressive ones. What does that mean for us as nurses? What's the significance of that distinction?
Well, what's truly fascinating here is that while many systems are indeed reversing the effects of pregnancy, like the uterus shrinking back, which we call involution, others are making progressive adaptations. Think about the initiation and establishment of lactation. That's a huge forward step, not a reversal. This dual process highlights the immense complexity of postpartum recovery. As nurses, understanding both retrogressive and progressive changes allows us to anticipate the full spectrum of a client's experience. It means we're not just supporting healing from pregnancy, but also facilitating new, vital functions like breastfeeding. It's not simply about going back, it's fundamentally about moving forward into a new physiological and family state. It's a complete recalibration.
So, what does this all mean for the nursing student listening in right now? How crucial is our role during this intense period, especially given how much is happening at once to the client and their family? It feels like a lot.
Oh, your role is absolutely critical. Imagine your client just hours or days postpartum. Their body is recovering from this monumental event. Hormones are fluctuating wildly, and they're learning to care for a brand new human. You are on the front lines, the expert guide. Your keen assessment skills are vital for monitoring physiological recovery, identifying potential complications early before they escalate. You're also providing essential education, promoting comfort, fostering that initial bonding between parent and infant, and supporting overall family adaptation. Without your vigilance and effective education, critical complications could be missed, and families might feel completely overwhelmed and unsupported. Empowering clients with confidence and ensuring safety through early recognition and education are absolutely paramount.
Okay, let's start with the reproductive system. Our sources say this is where the most immediate and dramatic adjustments take place. First up, uterine involution. What's the most critical insight for us to understand about this process? Why is it so fundamental?
Right, involution. The most critical insight is that its predictable daily pattern is your earliest, most vital warning system for postpartum hemorrhage. If it deviates, you must act immediately. So involution is the process where the uterus returns to its non-pregnant size and condition. It typically shrinks back to about pre-pregnancy size by 6 weeks postpartum. This happens through three key mechanisms. The strong, sustained contraction of muscle fibers around blood vessels at the placental site. This is crucial for clamping down and preventing hemorrhage. Then there's the breakdown and reabsorption of excess uterine tissue and the regeneration of the endometrium, the uterine lining. The sources really emphasize that those contractions immediately after delivery act like living ligatures to stop bleeding. It's pretty amazing, actually.
That is amazing.
Yeah.
So here's where it gets really practical for our assessments. How do we track this process externally? What are the expected changes day by day? What are we feeling for?
Yeah, tracking fundal descent is one of your most critical assessments. Immediately postpartum, the fundus, the top of the uterus, is typically midway between the symphysis pubis and the umbilicus. But within about 12 hours after birth, it actually rises to the level of the umbilicus. That's a key point to remember. It goes up first. After that, it descends approximately 1 centimeter, or 1 finger breadth, per day. By about 14 days postpartum, it should no longer be palpable abdominally as it's receded back into the pelvis. This predictable pattern is vital because if involution fails to occur as expected, a condition called subinvolution, the client is at significant risk for hemorrhage.
Okay, and when we find a deviation from that pattern, particularly if the uterus feels boggy, what's our immediate non-negotiable nursing action?
Right. Here's your absolute priority as a nurse. If the uterus feels boggy on palpation, your immediate critical nursing action is to massage it firmly until it becomes firm. A boggy uterus indicates uterine atony, meaning the uterine muscle isn't contracting effectively, which allows for increased bleeding. While you're massaging, you also need to encourage the client to empty her bladder. A full bladder is a common culprit. It displaces the uterus and prevents it from contracting properly. If you have persistent uterine atony despite these interventions, that's an urgent complication. It requires immediate reporting to the provider as it's a leading cause of postpartum hemorrhage. And a critical action to remember: never massage without stabilizing the lower uterine segment. You want to prevent uterine inversion, which is rare but life-threatening.
Got it. Stabilize first. Now, after pains, painful. Who experiences them most, why, and what's our role in helping clients manage this?
They certainly can be. After pains are basically intermittent uterine contractions, the uterus continuing to contract to involute, and they are typically more intense in multiparous clients, those who've had previous births, because their uterine muscle tone is often decreased. They're also frequently stronger during breastfeeding. That's because the release of oxytocin, which triggers milk ejection, simultaneously stimulates those uterine contractions. They typically subside by day 3 postpartum, thankfully. Analgesics are safe and effective. As nurses, a key takeaway is to reassure clients that short-term pain meds are generally not harmful to the infant during breastfeeding. In fact, they can actually support milk letdown by improving comfort and relaxation, making the whole experience more positive.
Okay, that's good reassurance to offer. Now, lochia, this is a big one for assessment. It's not just discharge. It's like the body's vital internal report card on uterine healing, right? What should we be looking for? What's the normal progression we need to track?
Lochia is absolutely critical to monitor. Yes, it's the vaginal discharge as the uterus heals and sheds tissue. Understanding its predictable progression in type, color, and amount over time is paramount for spotting a red flag before it becomes an emergency. First, we have lochia rubra. This lasts from days 1 to 3 postpartum. It's dark red, bloody, and can contain small clots. That's normal. Then, lochia serosa appears from days 4 to 10. This is pink or brown tinged, more serosanguineous. Finally, lochia alba starts around day 10 and can last up to 6 weeks. It's white, cream, or light yellow in color. We also use standardized descriptors for the amount. Scant, less than a 1-inch stain on a peri pad in an hour. Light, less than 4 inches. Moderate, less than 6 inches. Heavy, a saturated pad in an hour. And excessive, a saturated pad in 15 minutes. Those last two are definitely cause for concern.
And our sources highlight 2 interesting points about lochia. Temporary gush when standing or breastfeeding is expected, and C-section clients often have less lochia. Why is that the case?
That's right, and these are important nuances to understand. The temporary gush is completely normal. It happens because blood can pool in the vagina when a client is lying down. Then, upon standing, or with the uterine contractions stimulated by breastfeeding, that pooled blood is released. It should still follow the normal color progression for that day postpartum. And C-section clients often have less lochia because during the surgery, the provider manually cleans out some of the endometrium from the uterus, so there's just less tissue that needs to be shed naturally. It's a key difference to keep in mind when assessing these clients, but you still monitor closely for excessive bleeding.
Makes sense. Okay, beyond the uterus, what about the other parts of the birth canal, the cervix, vagina, and perineum? What key changes are happening there, and how do we support healing and manage discomfort, especially if there are lacerations?
Right, the entire birth canal undergoes significant recovery. The cervix is initially dilated and edematous. It's a bit floppy, maybe. It gradually narrows by the end of the first week. A key point for you. The external axis remains slit-like after childbirth, rather than returning to its pre-pregnant round shape. That's a permanent change. The vagina is edematous initially. The rugae, those folds, reappear in 3-4 weeks, but full restoration can take 10 weeks. And lactating clients may experience vaginal dryness due to lower estrogen levels, which can affect comfort. The perineum, the area between the vagina and anus, may be bruised or edematous, especially with an episiotomy or laceration. Healing starts in 2-3 weeks, but can take months to feel completely normal.
And trauma during delivery, like lacerations, is a real possibility. What kinds might we encounter? How are they classified? And what's the critical nursing action if we suspect something serious?
Yes, lacerations are a significant concern. They contribute to pain, infection risk, and hemorrhage risk. They're classified by degree. Perineal lacerations can be first degree, superficial, just skin. Second degree into perineal muscles. Third degree through the external anal sphincter. Or fourth degree, which goes into the rectal mucosa. Midline episiotomies are classified similarly. You can also see periurethral lacerations near the urethra, causing painful voiding or retention, and vaginal wall lacerations. But a crucial one to remember are cervical lacerations. These can cause persistent, bright red bleeding even when the uterus is firm and well contracted. That tells you the bleeding isn't coming from uterine atony, it's from the cervix itself. So here's your critical nursing action for lacerations. For fourth-degree laceration, careful perineal care and pain management are vital. And critically, no rectal suppositories or enemas. You absolutely want to avoid disrupting that repair. If a client shows persistent bright red bleeding despite a firm fundus, you must immediately suspect a cervical laceration and notify the provider. This is urgent. For general perineal discomfort, key measures include ice packs, first 24 hours, then warm sitz baths, peri-bottle cleansing, topical anesthetics like sprays, witch hazel pads, and oral analgesics. Any pain that persists despite comfort measures or seems really disproportionate might indicate a hematoma or infection and needs immediate reporting.
Got it. No suppositories for the fourth degree, and suspect cervical if bleeding continues with a firm fundus. Okay, yeah. One last thing for the reproductive system. When can clients expect their cycles to return? And what does this mean for family planning? This is a really common and important question they ask.
Yes, this is vital client education. For non-lactating clients, ovulation may resume relatively early, maybe by 6-10 weeks postpartum. Menstruation usually returns within 2-3 months. However, for lactating clients, ovulation and menstruation are delayed. It usually returns between 10 weeks and 6 months, largely depending on the frequency and exclusivity of breastfeeding. This delay is due to the hormonal influence of prolactin. But here is the crucial nursing note, the thing you must communicate clearly. Contraception is necessary even before menses resumes, because ovulation can, and often does, occur before that first menstrual period. Misconceptions about this can easily lead to unintended pregnancies very soon after birth.
So important to stress that. Okay, shifting gears slightly, lactation is a huge progressive change in the postpartum period. How does it get started? What are the key hormonal drivers?
Lactation is a remarkable progressive change, yeah? And it's all driven by a very precise hormonal dance. After the delivery of the placenta, there's a rapid drop in estrogen and progesterone levels. This sudden decline, in turn, stimulates the release of prolactin, the hormone primarily responsible for initiating milk production. This usually happens within 2-3 days postpartum, though colostrum, that early milk, is available sooner. Once milk production begins, another hormone, oxytocin, becomes critical for milk ejection, or what we call letdown. That's the actual release of milk from the breast. So here's your critical nursing action based on that. For breastfeeding clients, encourage frequent nursing or pumping. Milk production is based entirely on a supply and demand system. The more the breasts are emptied, the more milk will be produced. This also helps prevent painful engorgement. For clients who are not breastfeeding, the advice is quite different. Counsel them to use a supportive bra, avoid any breast stimulation, even warm water in the shower running over them, and use cold compresses for engorgement relief. This helps suppress lactation naturally and comfortably.
Our bodies are truly amazing at adapting. Pregnancy causes like a 40–50% increase in blood volume. That's huge. What happens to all that fluid after birth, and how does the body handle the blood loss from delivery?
It is incredible, isn't it? This physiological hypervolemia during pregnancy is a built-in protective mechanism. It allows the client to tolerate the normal blood loss of childbirth without adverse effects, up to 500 milliliters for a vaginal delivery and up to 1,000 milliliters for a C-section. Interestingly, immediately after birth, maternal cardiac output actually temporarily increases despite this blood loss. This happens as blood from the uteroplacental circulation returns to the central circulation, uterine pressure on major vessels is relieved, and extracellular fluid begins shifting back into the vascular compartment. Cardiac output typically returns to pre-labor values within about an hour, and then back to pre-pregnancy levels within 6-12 weeks postpartum.
So how does the body get rid of all that extra fluid then? What can we tell clients to expect? Because they often notice things like sweating.
Right. The body has two primary ways to eliminate that increased plasma volume from pregnancy. The first is through diuresis, which is an increased urine output, often up to 3,000 milliliters per day, peaking around postpartum days 2 to 5. This happens as aldosterone and oxytocin levels decline. The second is diaphoresis, or profuse sweating, especially at night. This can be quite uncomfortable and even surprising for clients if they aren't warned. As nurses, it's important to explain that both heavy urination and night sweats are normal ways the body is getting rid of excess fluid. Encourage fluids to replace losses, suggest fresh clothing, and showers to promote their comfort during this phase. But here's your absolute non-negotiable as a nurse. You must vigilantly monitor for signs of hypovolemia or hemorrhage, even amidst this normal diuresis and diaphoresis. A rapid heart rate, a falling blood pressure, or the client reporting dizziness. These may indicate abnormal blood loss that requires immediate intervention, not just normal fluid shifts. These are flashing red lights you can't ignore.
Okay, blood work. It can be tricky to interpret postpartum because of all these fluid shifts we just talked about. What's considered a normal variation for things like WBCs, hemoglobin, and hematocrit? What should raise a red flag for us?
You're right. Interpreting labs postpartum requires knowing these normal physiological changes. For leukocytosis, white blood cell, WBC counts, can go as high as 30,000 millimeters during labor and the immediate postpartum period. This is a normal response to the stress of labor and tissue healing, and it usually returns to normal within 1-2 weeks. A key nursing note, though. While mild elevation is expected, an increasing WBC count or a persistent fever after the first 24 hours postpartum should definitely prompt an infection evaluation. Hemoglobin and hematocrit are difficult to interpret initially because of that plasma dilution. As the excess fluid is excreted through diuresis, the H/T concentration rises and usually normalizes in 4-6 weeks, unless there was excessive blood loss. So what's the warning sign here? A falling hematocrit when fluid balance seems stable, that can signal ongoing postpartum hemorrhage and needs immediate intervention.
Right. And what about the risk of blood clots postpartum? That hypercoagulable state always makes me think about DVT risk.
You're exactly right to think about it. Coagulation is a vital area to monitor. During pregnancy, clotting factors and fibrinogen increase significantly. These changes persist postpartum, creating a hypercoagulable state. This state increases the risk for venous thromboembolism, VTE, like DVTs or PEs, until about 4 to 6 weeks after birth. A key takeaway for your clinical practice: early emulation is highly effective in reducing this risk. Get your clients moving. For clients with additional risk factors like a C-section or a history of clotting disorders, pharmacologic anticoagulants or mechanical prophylaxis like sequential compression devices, SCDs, might be indicated. And always assess for signs of DVT, unilateral leg swelling, pain, redness, or warmth. Any suspicion needs immediate provider notification.
Okay, after all that effort during labor, clients are often really hungry and thirsty. Makes sense. But getting the GI system back on track can be a real challenge, can't it? What are the common issues we'll see? What's our primary goal?
Absolutely. Constipation is a very common issue for postpartum clients, and it's due to a whole bunch of factors. Residual progesterone effects causing sluggish bowel tone, relaxed abdominal muscles, maybe decreased intake during labor, perineal trauma or hemorrhoids causing pain and reluctance to defecate, and even iron supplementation can contribute. The first stool typically occurs within 2-3 days postpartum. So your primary goal is to prevent straining and promote comfortable, regular bowel movements. For management, encourage hydration, lots of fluids, and a fiber-rich diet. Promoting ambulation, especially after a C-section, is key for stimulating peristalsis and reducing gas pain. Administer stool softeners or laxatives as ordered, and reassure clients that this is temporary. Now, what's important to watch for? If constipation persists, or if you see severe abdominal distension and pain, especially after a C-section or extensive perineal trauma, you must evaluate for bowel obstruction or paralytic ileus. These are serious complications that require immediate attention.
The urinary system also undergoes significant changes. And we know bladder function directly impacts uterine contraction, which we just talked about for hemorrhage risk. What should we be vigilant about, particularly regarding bladder distension?
Yeah, the urinary system's recovery is closely tied to overall postpartum well-being. The kidneys return to normal function pretty quickly by 2 weeks, and that pregnancy-related dilation of the renal pelvis and ureters usually resolves in 2 to 8 weeks. The postpartum bladder, though, has increased capacity but decreased muscle tone. This can lead to incomplete emptying. Plus, trauma during birth can reduce sensation, so clients may void large amounts due to diuresis but not actually feel the urge, even with a full bladder. A nursing note here.
Yeah.
Urinary retention is common, especially after a first vaginal birth, regional anesthesia, or catheterization. And here's where it gets critical for hemorrhage risk. Overdistension and urinary retention significantly increase the risk for two major issues. First, urinary tract infection, UTI, due to urinary stasis, makes sense. Second, and crucially, a full bladder displaces the uterus upward and often laterally, preventing it from contracting effectively. This leads to uterine atony, a prime cause of hemorrhage. Your critical nursing action: always assess for bladder distension if the uterus is displaced or not firm. Encourage voiding frequently, or perform catheterization if necessary, because an empty bladder is paramount for proper uterine involution and hemorrhage prevention.
That connection between bladder and uterus is so important.
Mm-hmm.
What about stress incontinence? That's another common concern clients might have. What's the outlook, and what can we advise?
Right, stress incontinence, leaking urine with coughing, sneezing, laughing is quite common during pregnancy and early postpartum. The good news is, for most, it improves significantly with time and consistent pelvic floor or Kegel exercises. A key takeaway: reassure clients that it often resolves with healing, and encourage early and consistent pelvic floor exercises. These strengthen the muscles and improve long-term bladder control.
It's not just the core areas. The whole body has been through a lot. What kind of musculoskeletal recovery can clients expect, particularly regarding general aches and pains and the abdominal wall?
Oh, the entire body is recovering. Muscle fatigue and generalized aches, shoulders, neck, arms are very common in the first 1-2 days, just from the exertion of labor. Warmth and gentle massage can help. As relaxin levels decline, those pelvic ligaments and cartilage shift back, which can cause temporary hip and joint pain. Reassure clients these discomforts are temporary. Now, for the abdominal wall, which stretches significantly during pregnancy, diminished muscle tone is common. Diastasis recti, which is a separation of the rectus abdominis muscles, is also quite common. You can often feel it during assessment. Gentle exercises can help strengthen the wall, and it usually returns to near pre-pregnancy condition by 6 weeks. Your critical nursing action: assess for diastasis recti during the physical exam, educate on safe abdominal strengthening exercises, and advise avoiding vigorous exercise until cleared by the provider, usually at the 6-week checkup, to prevent making the separation worse.
That hormonal roller coaster affects skin and hair too, doesn't it?
Yeah.
What changes should we anticipate, and what can we tell clients about them?
Absolutely. Many hormone-driven skin changes start to resolve as estrogen, progesterone, and melanocyte-stimulating hormone levels decline. Pigment changes like melasma, the mask of pregnancy, and the linea nigra, that dark line down the abdomen, usually fade. Vascular changes like spider nevi or palmar erythema typically resolve. Stria gravidarum or stretch marks fade to silvery lines, but realistically they rarely disappear completely. And postpartum hair loss, which can be quite alarming for clients, is common for 20 weeks postpartum. It's a normal adjustment due to hormone shifts, with regrowth usually starting in 4-6 months. A key takeaway: postpartum hair loss is a frequent concern. Reassure clients it's temporary and hormonal, not nutritional deficiency. And of course, be alert for any skin changes that don't follow expected patterns, as these might indicate underlying conditions.
It's no surprise fatigue is a big issue postpartum. But what other neurological effects might we see, particularly related to the labor and delivery experience itself?
Fatigue is indeed profound, almost universal. After pains, perineal trauma, muscle aches, breast engorgement, they all interfere with sleep and contribute to exhaustion. Clients who had regional or general anesthesia may have temporary neurologic effects like leg numbness or dizziness. Your critical nursing action here: fall prevention is paramount. Always assist postpartum clients with their first ambulation after anesthesia. Their sensation and motor control may be temporarily impaired, making them unsteady.
Right, safety first. Now, mild headaches are common postpartum, but there's a specific, more severe type our sources highlight that we absolutely need to know about as BSN students. What is it, and how do we differentiate and manage it?
Yes, while mild headaches are common in the first postpartum week, often just from fluid shifts or fatigue, the one you must identify is a spinal headache, also called a post-dural puncture headache. This severe headache occurs when regional anesthesia, like an epidural or spinal, inadvertently causes a leak of cerebrospinal fluid, CSF. Key features to recognize. It's a severe throbbing headache that worsens dramatically when the client sits or stands upright and improves significantly when they lie flat. That positional nature is the hallmark. They might also have nausea, dizziness, or visual changes. Treatment usually starts with conservative measures: bed rest, lying flat, aggressive hydration, pushing fluids, caffeine, which can help constrict blood vessels, and analgesics. If it's persistent and severe, an epidural blood patch may be performed by anesthesia to seal the leak. What's important for you to remember here: any client reporting a severe positional headache after spinal or epidural anesthesia needs prompt evaluation by the provider or anesthesia team. This is an urgent issue that requires quick intervention to prevent prolonged discomfort and support recovery.
Okay, finally, let's bring it back to hormones, which seem to be at the core of so many of these physical changes we've discussed. What's the major rebalancing act happening in the endocrine system? And what's that key piece of information for clients regarding fertility we need to reinforce?
The hormonal changes after childbirth are incredibly dramatic, yes. After the placenta is delivered, levels of estrogen, progesterone, and human placental lactogen, HPL, drop rapidly. This sudden decline drives that postpartum diuresis we talked about and reverses many of the physiological changes of pregnancy. Prolactin, however, remains elevated for breastfeeding clients, and it's maintained by frequent nursing or pumping. In non-breastfeeding clients, prolactin levels decline, allowing menses to resume sooner. And that brings us back to the critical nursing note. Ovulation can occur before the first menstrual cycle returns, so contraception counseling is vital for all postpartum clients, regardless of feeding method. Your critical nursing action. Always assess breastfeeding status when educating about fertility, lactation, and contraception to avoid dangerous misconceptions and unintended pregnancies.
Right. Always circle back to contraception. Now, clients often have questions and sometimes unrealistic expectations about postpartum weight loss. What's a realistic timeline, and what should we tell them?
Postpartum weight loss is definitely a gradual process, and setting realistic expectations is key. Approximately 10-13 pounds are lost right at childbirth. That's the baby, placenta, amniotic fluid, and blood loss. An additional 5-8 pounds are often lost in the first week from diuresis, getting rid of that excess fluid, plus another 2-3 pounds from uterine involution and lochia discharge. Most of the remaining weight loss typically occurs in the first 3 months. Many clients return close to their pre-pregnancy weight by 1 year, especially if they started within the recommended weight gain limits during pregnancy and follow a healthy lifestyle postpartum. Reassure clients that it's a gradual process. Your critical nursing action. Teach safe weight loss strategies. This means a balanced diet, adequate fluids, and gradual return to exercise. Not restrictive dieting, especially for breastfeeding clients who need adequate calories for milk production.
Okay, now that we've covered the what of all these changes, let's dive into the how. Our time with clients in the hospital is often short, so what are the absolutely essential first steps in postpartum assessment? Where do we start?
Right. The assessment process is continuous and actually begins in the 4th stage of labor, that first 1-2 hours immediately after childbirth. This is a critical time. During this initial period, your primary focus is evaluating a client's physical stability. This includes checking vital signs frequently, assessing skin color, locating the fundus and checking its firmness, monitoring the amount and color of lochia, carefully inspecting the perineum for any edema, episiotomy, lacerations, hematomas, or hemorrhoids. You're also assessing pain level, IV fluid status, urinary output, the abdominal incision if it was a C-section, and checking sensation and movement if regional anesthesia was used. These initial findings are absolutely vital because they establish the client's baseline and will guide all your subsequent assessments throughout their stay.
Okay, baseline established. Beyond that immediate physical check, what information from the chart is crucial to gather quickly to get the full picture?
After ensuring immediate physical stability, a thorough chart review is essential. You need context. You'll be looking for critical background information like gravida and para, how many pregnancies, how many births, the type of birth, vaginal C-section of forceps, anesthesia used, any operative procedures, details about lacerations or episiotomy, relevant medical history, allergies, the chosen feeding method, breast or bottle, the infant's condition at birth, and key lab data. Specifically, hemoglobin, hematocrit, blood type, Rh factor, rubella status, hepatitis B status, syphilis screening results, and group B strep GBS status. A key takeaway for your clinicals. Review labs early. Identifying Rh negative clients, those who are rubella non-immune or GBS positive, ensures timely interventions like RoJam administration or necessary immunizations before they go home.
Good tip. Now, in the postpartum period, What are the top 2 complications we must always be vigilant for, and what are their common risk factors we should look for in that chart review?
As nurses, you must always, always remain vigilant for the two most common and serious complications in the postpartum period: hemorrhage and infection. For hemorrhage, key risk factors to look for include multiparity, having many previous births, prolonged or precipitous, very fast labor, uterine overdistension from a large infant, multiples or polyhydramnios, retained placental fragments, known coagulopathy, birth trauma, lacerations, hematoma, operative procedures like forceps or vacuum, or prolonged oxytocin use during labor. For infection, the risk factors include cesarean birth or operative vaginal delivery, multiple cervical exams during labor, prolonged rupture of membranes, manual extraction of the placenta, frequent catheterization, pre-existing diabetes, or known bacterial colonization like GBS. What's your absolute non-negotiable here? Handoff communication, whether bedside report or in the chart, should always highlight any identified risk factors for hemorrhage or infection. This ensures continuity of vigilance and enables early recognition and intervention, which truly saves lives.
Absolutely critical for handoffs. Okay, beyond those immediate risks, what immunizations are essential postpartum? What are the key teaching points for each one?
Right, several immunizations are crucial postpartum, often given before discharge. ROD, immune globulin, ROJAM. This is given within 72 hours of birth to Rh-negative clients who have delivered an Rh-positive newborn. It prevents the mother from forming antibodies that could affect future pregnancies. Always verify both maternal and newborn blood types before giving it. Rubella vaccine, MMR. If a client is found to be non-immune to rubella, the vaccine is given postpartum. Because it's a live virus, clients must be counseled to avoid pregnancy for at least 30 days after receiving it. Pertussis, Tdap, booster. This is recommended for all adults who will be in close contact with the infant, including parents, to reduce the risk of transmitting pertussis, whooping cough, to the vulnerable newborn. Cocooning, varicella vaccine. If the client is not immune to chickenpox, this vaccine is also offered postpartum, and again, pregnancy should be avoided for 1 month. For all immunizations, document administration thoroughly, confirm the client understands the reason for the vaccine and any precautions, especially regarding pregnancy, and provide written instructions.
Okay, this BUBBLE-HE mnemonic is a fantastic tool for BSN students, really practical. Let's break it down. We'll go through each element, highlighting the most critical assessments and interventions. How often are these focused assessments typically done?
The BUBBLE-HEE mnemonic is indeed invaluable. It provides a systematic way to ensure you cover all the key postpartum assessment points. Assessment frequency typically starts intensely, every 15 minutes for the first hour or two immediately after birth, then maybe every 4 hours for the next 12-24 hours, and then shifts to every 8-12 hours until discharge, depending on facility policy and client stability. It guides you through both physical and psychosocial aspects. So the first B is for breasts. Beyond just looking at symmetry or checking for engorgement for breastfeeding clients, your critical eye needs to be on nipple integrity and the quality of the latch. Redness, blisters, fissures, cracks, that's trauma. It signals a problem with the latch that impacts milk transfer, causes pain, and can lead to infection. We need to intervene early. For non-breastfeeding clients, remember your goal is gentle suppression. Supportive bra, avoid stimulation, cold compresses for engorgement. Early skin-to-skin contact is great for promoting bonding and initiating breastfeeding, and any breast assessment is a perfect teaching opportunity. Next up, U for uterus, fundus. As we've stressed, this is crucial for monitoring involution and hemorrhage risk. You're palpating for consistency. Should be firm, like a grapefruit, not boggy. Its height relative to the umbilicus, measured in finger breadths above or below, and its position should be midline, not displaced laterally. A firm, midline descending fundus is what you want to see. A boggy, displaced, usually by a full bladder, or elevated fundus requires action. If it's boggy, massage it gently but firmly until it contracts. Ensure the bladder is empty, check lochia, and report persistent bogginess. And always remember, stabilize the lower uterine segment with one hand before massaging the fundus with the other to prevent uterine inversion. The second B is for bladder. You're assessing the client's ability to void spontaneously, the frequency and amount of each void, and checking for signs of distension. Distension might look like a palpable bulge above the symphysis pubis, or it might be the cause of that displaced uterus you felt. Incomplete emptying is common initially. Encourage voiding every 2-3 hours. Measure the first few voids to ensure adequate output, usually looking for 150 milliliters per void. If the bladder is distended and the client can't void, assist with ambulation. Try voiding promotion techniques, privacy, running water, warm water over the vulva, or catheterize if necessary per orders. Remember, frequent small voids, 150 millirel, can actually be a sign of urinary retention with overflow voiding. Moving on to the third B for bowel, you're asking about passing flatus, a good sign peristalsis is returning, their last bowel movement, and checking for any discomfort. Inspect the perineum for hemorrhoids. Constipation is very common, as we discussed. Encourage hydration, fiber, and early ambulation. Administer stool softeners or laxatives as ordered. Offer comfort measures for hemorrhoids like sitz baths or topical treatments. Reassure clients about stitches and fear of pain with the first BM. If constipation persists or severe abdominal distension pain occurs, remember to evaluate for potential obstruction. Then we have L for lochia. You're assessing the amount, color, odor, and presence of clots, remembering that normal progression. Rubra, dark red, days 1-3, serosa, pink-brown, days 4-10, and alba, white creamy yellow, day 10 up to 6 weeks. Observe the peripads, document the amount using those standard terms, scant, light, moderate, heavy, excessive, and weigh pads if you suspect heavy bleeding for a more accurate quantification. Teach clients the warning signs to report. Sudden increases in amount, saturation of a pad in an hour or less, a return to bright red rubra after it had progressed to serosa or alba, foul odor, or passing large clots bigger than a golf ball usually warrants investigation. Your absolute priority finding here. A constant trickle or steady oozing of bright red blood, even when the uterus is firm, suggests a laceration, cervical or vaginal, is bleeding, not uterine atony. This requires immediate provider notification for inspection and possible repair. The first E is for episiotomy, lacerations, or incisions. You need to inspect the perineum carefully. Is it intact or is there trauma? Use the Rita mnemonic to assess any episiotomy or laceration repair. Redness, edema, ecchymosis, bruising, discharge, and approximation are the edges well aligned. If the client had a C-section, you assess the abdominal incision using Rita as well. For perineal discomfort, apply ice packs for the first 24 hours, then transition to warm sitz baths. Topical anesthetics, sprays, creams, and oral pain medication are crucial for comfort. Teach meticulous perineal hygiene. Use the peri bottle with warm water after each void BM, wipe front to back, pat dry gently, change pads frequently, and wash hands before and after. Good pain management with ice, sitz baths, and analgesics is really key for comfort and healing. Next, we have H for hemorrhoids. These are common or can worsen due to pushing during labor. You're inspecting the rectal area for these swollen varicosities and asking about discomfort, especially with bowel movements. Nursing care focuses on preventing constipation, hydration, fiber, stool softeners, and providing comfort, which hazel pads like Tux, ice packs, warm sitz baths, hydrocortisone ointment, and encouraging side-lying positions to reduce pressure. Reassure clients they usually improve significantly postpartum. The second E is for edema, lower extremities, and DVT risk. Some pedal or pretibial edema is common due to fluid shifts, but it should decrease with diuresis over the first few days. Check pedal pulses and skin trigger. But critically, you must inspect the legs for signs of DVT. Look for redness, warmth, or asymmetry, one leg noticeably more swollen than the other. Ask about pain or tenderness. Remember, Homan's sign, pain on dorsiflexion of the foot, is outdated and unreliable. Rely on clinical signs, unilateral leg pain, swelling, tenderness, or heat. Encourage early and frequent ambulation. Use SCDs if the client is on bed rest. Ensure adequate hydration. Teach clients to report any sudden pain, swelling, redness, or warmth in their legs immediately. Mild bilateral swelling is usually normal, but sudden onset or unilateral swelling needs immediate evaluation for DVT. And finally, the last E is for emotions bonding. This is just as important as the physical checks. You're assessing the client's overall emotional status, mood, and effect. Are they tearful, anxious, withdrawn, elated? Observe bonding behaviors between the parents and infant. Are they holding the baby close, making eye contact in face position, talking to the infant, touching and exploring? Monitor for signs of postpartum blues, common, transient, versus more serious postpartum depression or anxiety. Encourage rooming in, keeping baby in the room, and skin-to-skin contact to facilitate bonding. Allow clients to verbalize their feelings without judgment and reassure them about common mood changes, baby blues, your absolute priority. Immediate evaluation and referral are necessary if a client shows signs of withdrawal, persistent sadness, inability to care for the newborn, expresses hopelessness, or, most urgently, voices any thoughts of harming themselves or the infant.
Okay, that BUBBLE-HEE is comprehensive. Now, a significant percentage of births, nearly a third, are C-sections. This means clients are recovering from both childbirth and major abdominal surgery. What are the key special considerations for us as nursing students when caring for these clients?
Yes, this is a critical population you'll encounter frequently. C-section clients are indeed recovering from major abdominal surgery in addition to all the normal postpartum physiological and psychosocial changes. Their typical hospital stay is longer, often 72-96 hours, to accommodate the surgical recovery.
Pain relief is always a priority, but maybe even more so after surgery. How does C-section pain management differ? What are the options and their unique side effects we need to monitor closely?
Pain management is absolutely paramount after a C-section. It's not just for comfort. Adequate pain relief is essential to allow the client to bond with their baby, ambulate early, and successfully initiate infant feeding. C-section clients often have unique perspectives. They're usually eager to be alert and engaged with their newborn, may be concerned about analgesics passing into breast milk, and desire some control over the pain management. Common options include neuraxial opioids, like a single dose of long-acting morphine or fentanyl given during the spinal or epidural anesthesia. This can provide excellent pain relief for 18 to 24 hours. However, it requires close monitoring for side effects, particularly itching, pruritus, nausea, vomiting, urinary retention, and the most serious one, respiratory depression. Oral, or IM analgesics like NSAIDs or opioids are used for breakthrough pain or as the neuraxial effects wear off. PCA, patient-controlled analgesia pumps, might also be used, again requiring vigilance for side effects like respiratory depression, itching, nausea, vomiting, and urinary retention. For respiratory depression with opioids, your absolute priority is prompt intervention. If the respiratory rate drops below 12 breaths per minute or oxygen saturation, SpO falls below 95%, you need to notify the anesthesia provider immediately, elevate the head of the bed, apply oxygen, have naloxone Narcan readily available, and monitor closely for recurrence after intervention.
Okay, respiratory depression is the big one to watch with opioids. What are the specific assessment differences for a C-section client beyond the standard BUBBLE-HE checks?
Right. In addition to the routine postpartum BUBBLE-HE assessment, C-section clients require a full post-operative evaluation. You'll monitor respirations much more closely, especially rate and depth, for at least 18 to 24 hours if they receive neuraxial opioids, often using continuous pulse oximetry or sometimes an apnea monitor. For the abdomen, you need to auscultate for the return of bowel sounds and watch vigilantly for signs of paralytic ileus. That's when the bowel stops moving. Signs include abdominal distension, absent bowel sounds, nausea, vomiting, and no passage of flatus. You'll also assess the surgical dressing for drainage and later the incision itself using the RETA acronym. When palpating the fundus, do it gently to avoid causing unnecessary pain at the incision site. And for intake and output, monitor the IV site and fluids, track urine output closely, the Foley catheter is usually removed within 12 to 24 hours, and advance their diet slowly as tolerated and per protocol, usually starting with clear liquids.
Makes sense. What are the key nursing interventions specifically geared toward C-section clients, especially for preventing common post-op complications like pneumonia or abdominal distension?
Key interventions target both comfort and prevention. In the first 24 hours, focus on providing consistent pain relief to facilitate movement. Assist with that crucial first ambulation out of bed. They are a significant fall risk initially due to anesthesia effects, pain, and potential orthostatic hypotension. Encourage coughing, deep breathing exercises, and using an incentive spirometer frequently to prevent atelectasis and pneumonia. Teach them how to splint their incision with a pillow when coughing or moving to reduce pain. Simple leg and foot exercises while in bed, and the use of SCDs are important for DVT prevention until they are ambulating well. After the first 24 hours, if they are stable, the Foley catheter and IV fluids are usually discontinued. The surgical dressing might be removed per orders, allowing you to assess the incision directly each shift. Staples or sutures are often removed prior to discharge, with steri strips applied. You'll encourage increasing activity sitting in a chair, walking in the halls, showering, and their diet will progress as bowel function returns. To prevent abdominal distension, which causes significant discomfort from gas pain, encourage early and frequent ambulation, teach pelvic lifts in bed, advise avoiding drinking through straws or consuming carbonated beverages, which increase gas, and administer medications like simethicone or possibly rectal suppositories if ordered. And don't forget infant feeding. Pain really interferes. Help clients find comfortable positions that protect the incision, like the football hold or side lying, using plenty of pillows for support. Encourage partners or support persons to help bring the baby to the client initially.
Lots of practical tips there. What are the specific discharge teaching points unique to C-section clients that we absolutely need to reinforce before they go home?
For C-section discharge teaching, you'll cover all the general postpartum self-care topics, but add crucial instructions related to the surgery. This includes meticulous incision care, how to keep it clean and dry, signs of infection to watch for, increasing redness, warmth, swelling, foul-smelling drainage, pus, or wound separation dehiscence. Review how to manage steri strips if they are in place. They need clear instructions on when to call the provider. Fever, worsening abdominal pain, heavy lochia, urinary or bowel problems, or any concerns about the incision. Advise them to avoid heavy lifting, usually nothing heavier than the baby, around 10 pounds, for several weeks, until cleared by their provider at the follow-up visit. And importantly, strongly encourage them to arrange for support at home. Recovering from major surgery while caring for a newborn is demanding, and having help with meals, chores, and other children is essential for rest and recovery.
Ultimately, our goal is to empower clients for a safe and confident transition home. Discharge teaching feels so important, but sometimes rushed. How do we ensure it's effective, especially given the limited time we often have and how overwhelmed new parents can feel?
You're right. Effective discharge teaching is absolutely paramount for a safe transition, and it often feels like there's so much to cover in so little time. The key is that discharge teaching shouldn't be a single event crammed in right before they walk out the door. It starts at admission and should be continuous throughout the hospital stay. Use diverse strategies, don't just lecture. Incorporate videos, written materials, return demonstrations like having them show you how they use the peri bottle, and importantly, the teach-back method to confirm understanding. Can you tell me in your own words the signs of infection you need to watch for? Assess their individual learning needs and concerns early on. Consider parity multi-paras might just need a review, while premi-paras often need thorough, step-by-step instruction. Be mindful of learning barriers like pain, fatigue, anxiety, language, or cultural differences. Provide information in short, focused sessions rather than one long, overwhelming one. Always supplement verbal teaching with clear, easy-to-read written instructions they can refer back to at home. Things like AHON's post-birth warning signs handout are excellent tools. Your expected outcome is that by discharge, the client can confidently verbalize and demonstrate understanding of self-care practices, describe health promotion strategies, and clearly identify follow-up needs and critical danger signs requiring immediate attention. When preparing to teach, ensure the client is comfortable, offer pain medication if needed beforehand. Try to schedule teaching sessions around meals, feeding times, or visitor restrictions. Prioritize the most critical topics with the client, ask them what they feel most anxious or unsure about.
That's great advice. Make it ongoing, interactive, and prioritized. Let's break down the essential self-care teaching topics in detail now, starting with the absolute basics.
Absolutely. Let's get specific. For hand hygiene, stress the importance of thorough hand washing before and after handling breasts, touching the infant, changing peri pads, or performing any perineal care. Simple but crucial for preventing infection. For breast care, lactating clients, advise avoiding soap on the nipples can be grind irritating. Keeping nipples dry between feedings, air dry if possible, and wearing well-fitting supportive bras, not too tight. For engorgement, suggest warm showers or warm compresses just before feeding to help milk flow. Ensure the breasts are emptied as completely as possible with each feeding or pumping, and use cool compresses after feeding for comfort. Sore nipples might benefit from applying expressed breast milk, purified lanolin, or hydrogel pads. Breast shells can help with flat or inverted nipples. Non-lactating clients, they need a snug, supportive bra worn continuously for the first 72 hours or so. Advise them to strictly avoid any breast stimulation, including letting warm water run over them in the shower, as this encourages milk production. For engorgement, which typically peaks around days 3 through 5, recommend cold compresses, applied intermittently, like 15 minutes on, 45 minutes off. Crushed cabbage leaves tucked inside the bra, sounds strange, but many find it soothing. And mild analgesics like ibuprofen for discomfort. For care of the cesarean incision, review specific instructions based on the closure method: staple, sutures, glue. Teach them to keep it clean and dry and report any signs of infection: redness, warmth, swelling, foul odor, increased drainage, pus, or wound separation. For perineal care, demonstrate and have them demonstrate proper peri bottle use. Fill with warm water, squirt front to back after each void BM, don't touch the tip to the perineum. Reinforce frequent pad changes at least every 3 to 4 hours or sooner if needed, applying and removing pads front to back and proper disposal. Reinforce checking their perineum with a mirror for Rita signs. And definitely teach Kegel exercises. Explain how to identify and squeeze the pelvic floor muscles to help regain tone, support pelvic organs, and prevent stress incontinence. Encourage doing them multiple times a day.
Rest and nutrition are so vital for recovery, but often hard for new parents to prioritize. What should we emphasize?
Yes, they're fundamental but challenging. To promote rest and sleep, encourage realistic expectations. Advise them to sleep when the baby sleeps. Even short naps help. Encourage limiting visitors and calls, especially initially. Stress the importance of accepting offers of help with meals, chores, or other children. Provide anticipatory guidance that fatigue is normal and often prolonged for weeks or months. If fatigue seems excessive or persists beyond 2-3 weeks, advise them to contact their provider to rule out underlying issues like anemia, infection, or thyroid dysfunction. For nutrition counseling, encourage a balanced diet rich in protein for tissue repair, complex carbohydrates for energy, fruits, and vegetables. Stress the importance of adequate hydration, especially for breastfeeding. Aim for 8-10 glasses of water fluids per day. Provide referrals to resources like WIC or SNAP-TANF if food insecurity is a concern.
Okay, and what about getting the bowels and bladder back on track and returning to activity and exercise?
For bowel and bladder function, review strategies to prevent constipation. Plenty of fluids, high-fiber foods, regular walking, and trying to establish a routine for bowel movements. Reinforce perineal comfort measures for hemorrhoids, witch hazel, hydrocortisone creams. For bladder function, encourage frequent emptying, teach strategies if they have difficulty voiding, and review the signs and symptoms of a UTI: burning, pain, frequency, urgency, flank pain. For exercise and body mechanics, teach gentle postpartum exercises they can start soon after birth, like abdominal tightening pelvic tilts, Kegels. Encourage walking as tolerated, gradually increasing duration and intensity. Emphasize using good body mechanics for lifting the baby, bending, and infant care to prevent back strain. Advise avoiding strenuous exercise or heavy lifting until cleared by their provider, usually at the 6-week checkup.
What about resuming sexual activity and the need for contraception? That's a sensitive but really important topic clients will likely have questions about.
It absolutely is, and we need to address it proactively and sensitively. For sexual activity and contraception, provide anticipatory guidance. Let them know it's generally safe to resume intercourse once bleeding has stopped, the perineum is healed, usually around 24 winks, but varies greatly, and importantly, when they feel ready physically and emotionally. Normalize that decreased libido is very common due to fatigue, hormonal changes, body image concerns, or perineal discomfort, vaginal dryness, especially if breastfeeding. Recommend using water-soluble lubricants. Most importantly, discuss contraceptive options thoroughly before discharge. Review different methods, hormonal, barrier, LARCs like IUDs, permanent, considering the client's medical history, breastfeeding status, some hormonal methods are preferred, financial situation, cultural beliefs, and personal preferences. Reiterate emphatically that ovulation can occur before the first menstrual period, making contraception essential to prevent unintended pregnancy.
Okay, essential conversations. Finally, what about follow-up care and that absolutely crucial danger list of signs and symptoms clients need to report immediately? This feels like the most critical take-home message.
Absolutely. Reinforce the importance of attending their scheduled postpartum follow-up appointments. Traditionally, this was at 6 weeks, but guidelines now recommend earlier contact. For a vaginal birth, follow-up is often around 3-6 weeks. For a C-section, they usually have an incision check around 1-2 weeks, and then a comprehensive visit at 6 weeks. The American College of Obstetricians and Gynecologists, ACOG, actually recommends contact with a care provider within the first 3 weeks postpartum, followed by a comprehensive visit no later than 12 weeks. Now, for the signs and symptoms to report the danger list, this is where your teaching needs to be crystal clear, and you should use teachback to ensure understanding. They need to call their provider for. Fever greater than 100.4 degrees F, 38 degrees C after the first 24 hours postpartum. Signs of breast infection, mastitis. Localized redness, heat, swelling, body aches, flu-like symptoms, or significant pain in one breast. Severe abdominal pain not relieved by medication or increasing pelvic pressure. Abnormal lochia, soaking through more than one pad per hour, passing large clots, golf ball size or bigger. Lochia returning to bright red after progressing or having a foul odor. Signs of a UTI, burning or pain with urination, increased frequency or urgency, difficulty voiding, or blood in the urine. Signs of DVT in the leg, localized pain, tenderness, redness, warmth, or swelling, especially if unilateral. Signs of wound infection, perineal or C-section. Increasing redness, pus, foul-smelling drainage, warmth, or wound separation. Severe headache, especially one that doesn't improve with usual remedies, is positional or is accompanied by vision changes. Could be preeclampsia-related or spinal headache. And critically, they need to call 911 or go to the nearest emergency department for chest pain, difficulty breathing or shortness of breath, seizures, or any thoughts of harming themselves or their baby. These are true emergencies.
Okay, shifting gears from the physical to the psychosocial. It's not just the body recovering, the mind and emotions are in overdrive too. How do we define the crucial processes of bonding and attachment? Why are these distinctions important for our nursing care?
This is a really important distinction for nurses to understand, as they underpin the developing parent-infant relationship. Bonding is typically defined as that rapid initial attraction the parent feels towards the infant. It's often described as unidirectional parent to infant. It's thought to be enhanced by immediate skin-to-skin contact, especially during the infant's quiet alert period in the first hour or so after birth. In contrast, attachment is the enduring reciprocal relationship that develops over time. It's built through ongoing, pleasurable, and responsive interactions between the parent and infant over weeks and months. It's a two-way street. To foster this, as nurses, we should encourage and facilitate early skin-to-skin. Dry the infant and place them directly on the birthing parent's bare chest, or the partner's. Delay non-urgent procedures like bathing or eye ointment for that first hour if possible. Support a safe latch or responsive bottle feeding during this time. A nursing note. If early contact is limited due to complications like baby going to NICU or mom needing recovery, reassure parents that attachment can still develop beautifully. Prioritize comfort, pain control, and supported contact as soon as it's medically feasible.
Okay, bonding is initial attraction, attachment is the ongoing relationship. Now, our sources describe three distinct puerperal phases for maternal role attainment: taking in, taking hold, letting go. Let's walk through them. This gives us great insight into the emotional journey.
Yes, these phases, described by Riva Rubin years ago but still relevant, help us understand the mother's typical psychological adjustment to her new role. First is the taking in phase. This usually lasts from birth through the first day or two postpartum. Her focus is largely inward on her own immediate needs: sleep, food, fluids. She's often passive, dependent, and needs to process the birth experience by talking about it. A key nursing note. Invite her to share her birth story, validate her feelings, listen actively, and cluster your care to protect her much-needed rest. Second is the taking hold phase. This typically begins on day 2 or 3 and can last for several weeks. Here, she starts to shift focus to the baby and resumes more control over her own care. She shows increasing independence and is highly receptive to teaching about infant care, but may also express anxiety about her parenting skills. Am I doing this right? This is your prime, teachable, reachable, referable window. Praise her efforts, offer positive reinforcement, patiently coach skills, and encourage partner participation. Finally, there's the letting go phase. This occurs over weeks and months as she integrates the parenting role into her life. It involves accepting the reality of her infant and her new role, sometimes grieving the loss of her previous life or fantasized birth experience. It includes reestablishing relationships, like with her partner, and adapting to new roles, perhaps including returning to work. Normalize these complex and sometimes mixed feelings, offer anticipatory guidance about role renegotiation, and connect her with community resources or support groups.
Beyond these general phases, what are some other major maternal concerns we should be prepared to address? And critically, let's talk about the difference between common baby blues and something more serious, like a perinatal mood and anxiety disorder, PMAD. This distinction is vital.
Right. Several common concerns come up. Body image is a big one. Many women feel distressed about their postpartum body. It's important to set realistic expectations for gradual weight loss and return to fitness. Emphasize nutrition that supports healing and lactation, not dieting. Focus on function and strength. Smoking relapse prevention is another. Pregnancy is often a motivator to quit, but the stress of postpartum can trigger relapse. Discuss the significant risks of postnatal smoking and secondhand, third-hand smoke exposure for the infant. Provide cessation resources and strategies, encourage smoke-free environments, and involve partners if possible. Now, the distinction between baby blues and perinatal mood and anxiety disorders, PMADs, is absolutely essential knowledge for every nurse interacting with postpartum families. Postpartum blues, or baby blues, is very common, affecting 50–80% of clients. It typically has an onset in the first week, peaks around day 5, and resolves spontaneously by 2 weeks postpartum. Symptoms include tearfulness, mood swings, irritability, anxiety, fatigue, and forgetfulness. But crucially, the client's overall functioning is generally not impaired. They can still care for themselves and the baby, even if they feel weepy. When it's potentially more than the blues, meaning it could be postpartum depression, anxiety, OCD, PTSD, or rarely psychosis, the symptoms are more severe, persistent, lasting beyond 2 weeks, and significantly interfere with functioning. Look for escalating sadness, hopelessness, overwhelming anxiety, panic attacks, intrusive thoughts, sometimes scary thoughts about the baby, significant changes in appetite or sleep beyond normal newborn disruption, inability to care for self or infant, or loss of pleasure in usual activities. Psychosis involves hallucinations, delusions, or paranoia, your absolute priority. Immediate escalation and referral for psychiatric evaluation are necessary if a client expresses suicidal ideation, any thoughts of harming the infant, exhibits signs of psychosis, or shows severe functional impairment. These are psychiatric emergencies requiring prompt and decisive intervention. Screen routinely for PMADs and know your facility's referral process.
Our deep dive wouldn't be complete without acknowledging the profound impact of culture on the postpartum experience. How do we provide truly culture-specific or culturally responsive care that respects each family's unique beliefs and practices during this vulnerable time?
Providing truly culturally responsive care is fundamental to holistic nursing, especially during the postpartum period, which is rich with cultural traditions worldwide. The core goal is to provide care that explicitly respects and incorporates, whenever safe and feasible, each family's health beliefs, values, and practices. A crucial nursing note. Always ask before you assume. Don't stereotype based on ethnicity or appearance. An open-ended, respectful question like, are there any cultural or religious traditions related to childbirth and recovery that are important to you or your family that you'd like us to know about or support while you're here is invaluable. This simple question opens the door for families to share what matters most to them and builds trust.
Communication itself can be a major cultural barrier, even beyond language. How do we ensure effective communication, especially when language differs or modesty is a significant concern?
Communication is indeed multifaceted. Language, dialect, nonverbal cues, beliefs about eye contact, personal space, and modesty norms all shape how families receive and perceive information and care. When there's a language barrier, your critical skill is working effectively with the professional medical interpreter. Request one-use in-person, phone, or video services provided by your facility. Briefly pre-brief the interpreter on the goals and any sensitive topics. During the interaction, face the client, not the interpreter. Speak in short, clear sentences, avoiding jargon or slang. Pause frequently to allow for interpretation. Use the teach-back method through the interpreter to confirm understanding. Document the interpreter's name and ID number, your absolute priority. Never use family members, especially children, friends, other clients, or untrained staff as interpreters. The risks of errors, omissions, breaches of privacy, and altered power dynamics are simply too high. Regarding modesty, always prioritize privacy for all clients. Knock before entering. Offer same-gender staff when feasible and requested. Provide extra gowns or drapes. Explain every procedure and touch before doing it, especially for cultures with heightened modesty needs. For example, explaining perineal assessment clearly before proceeding.
Many cultures have specific postpartum practices, often centered around concepts like rest, warmth, diet, and social support. How do we integrate these at the bedside, particularly if they seem to conflict with standard Western medical practices like early ambulation or using ice packs?
This is a very common scenario and requires cultural humility and flexibility from us. Many cultures emphasize a period of extended rest. Specific dietary practices often involving hot foods and avoiding cold ones, maintaining body warmth, and having strong female kin support, like the concept of doing the month in East Asian cultures or the quarantena in Latin American cultures. Practices might include limiting bathing or hair washing, avoiding cold air or drafts, and restricting activity. This means you need to be adaptable and collaborative at the bedside. For rest and roll relief, acknowledge and support the cultural value placed on extended rest. Enlist family support for infant care and household tasks to allow the mother to recover. For warmth preference, if ice packs for perineal pain are declined, offer alternatives like cool, not icy compresses, witch hazel pads stored at room temperature, or transitioning sooner to warm sitz baths, usually acceptable after the first 24 hours. Ensure the room isn't overly cold. For hygiene, respectfully, if daily showering or hair washing is declined, don't push. Instead, reinforce meticulous peri-bottle cleansing, front-to-back blotting padding dry, frequent pad changes, and excellent hand hygiene. Offer alternatives like a warm basin bath or warmed wipes. For prayer and rituals, facilitate quiet space and appropriate timing for religious practices. Clarify any restrictions related to postpartum bleeding if relevant. 2G participation in certain religious activities. What's important for you to remember here, if a cultural practice seems to conflict directly with safety, for example, refusing essential medication, severe restriction of fluids, engage in respectful negotiation. Explain the rationale for the medical recommendation clearly and simply. Explore compromises. Can we offer warmed beverages instead of iced water? Can sitz baths be shorter and warmer with supervision? Can the room be kept warm while still ensuring infant-safe sleep practices, no overheating?
That negotiation and compromise seem key. Dietary practices can also be very culturally specific. How do we support nutritional needs while respecting these beliefs, especially those related to hot-cold balance?
Dietary practices are deeply embedded in cultural postpartum recovery traditions. Many non-Western cultures operate on a hot-cold or humoral balance framework, where pregnancy and birth are often seen as hot states, and postpartum is a cold state requiring hot foods and avoidance of cold foods drinks to restore balance. Your nursing support involves being flexible. Offer warm or room temperature beverages like broth, tea, warm water, if cold water or ice is unacceptable. Encourage family members to bring in traditional, culturally appropriate foods that the client finds restorative, as long as they don't interfere with any medical dietary restrictions, like for diabetes. Collaborate with the dietary department if possible. Integrate your essential nutrition counseling goals, adequate hydration, protein for healing, fiber for bowels, sufficient calories for lactation within the family's preferred foodways. A helpful nursing note. Instead of just listing foods we think are healthy, ask open-ended questions like, what foods or drinks feel most nourishing and restorative for you after giving birth? This approach builds trust and allows you to tailor your advice effectively.
That's a great question to ask. And just for those moments when we need quick, on-the-spot adjustments for common cultural conflicts, what are some go-to alternatives we can offer?
Right, having some quick alternatives in your back pocket is really helpful. Ice pack declined for perineal pain. Offer a cool compress, less intense cold, room temp witch hazel pads, encourage side lying to reduce pressure, and suggest warm sitz baths after 24 hours. Iced water refused. Offer warm tea, broth, soup, or room temperature water. The goal is hydration. The temperature often matters less medically than culturally. Daily shower declined. Reinforce excellent peri-care with the bottle. Offer a warm basin bath for partial cleansing, or provide warmed wipes for freshening up. Concerns about early ambulation related to modesty or beliefs about rest. Offer extra gowns or robes for better coverage. See if a same-gender staff member or family member can chaperone. Clearly explain the rationale, preventing blood clots, helping bowels move, and start with short assisted walks. These small adaptations show respect, build rapport, and can make a huge difference in the client's comfort, trust, and overall experience.
We've covered so much ground: physical healing, emotional adaptation, cultural care. But what about medications? We've touched on some, but can you give a quick overview? What categories might a postpartum client typically need, and what's our core role as nurses in administering them and teaching about them?
Sure, postpartum clients may indeed require a variety of medications, and your role in safe administration and education is critical. Common categories include pain management, which we discussed, NSAIDs like ibuprofen, acetaminophen, Tylenol, and sometimes opioids for moderate to severe pain, especially post-C-section or with significant perineal trauma. Medications for elimination and bowel function, primarily stool softenals like docusate sodium to prevent straining, and sometimes laxatives if needed. Anemia correction, often requiring iron supplements if the client had significant blood loss or was anemic during pregnancy. Topical preparations for skin or nipple care, like hydrocortisone creams for hemorrhoids or purified lanolin for sore nipples and breastfeeding clients. Antiemetics for nausea or antihistamines like diphenhydramine Benadryl for itching might be used to manage side effects of anesthesia or opioids, especially after a C-section. And as we covered, postpartum vaccines like rubella, MMR, varicella, Tdap, and sometimes influenza are essential for protecting both the client and indirectly the newborn. ROGAM also falls under medication administration. Your role as the nurse is multifaceted. Ensuring the rights of medication administration, right patient, drug, dose, route, time, documentation. Accurately assessing the need for PRN meds. Thoroughly teaching clients about the purpose, expected effects, potential side effects, and any necessary precautions, like avoiding pregnancy after live virus vaccines or how iron can cause constipation. You need to ensure they understand how to take the medications correctly at home, especially regarding breastfeeding compatibility if applicable. Hashtag tag tag outro.
Wow, what an incredible deep dive into postpartum nursing care. We've really covered the gamut, haven't we? From the microscopic changes within the uterus to the huge emotional shifts in a new family, and importantly, how you, as nurses, can confidently navigate it all.
Absolutely. To quickly recap the biggest takeaways, remember the profound physical recovery that's happening. Understand the predictable pattern of uterine involution and lochia progression. Know that your regular, focused assessments, fundus, lochia, bladder, vital signs, perineum are your earliest detectors of potential complications like hemorrhage or infection. Recognizing normal versus abnormal is crucial.
And don't forget the critical importance of comfort and safety. It's not just about preventing disaster. It's about promoting healing. That means proactively managing common discomforts like hemorrhoids, perineal trauma, constipation, and urinary challenges, using interventions like ice, heat, analgesics, stool softeners, early ambulation, hydration, and diligent perineal care. These actions prevent serious complications and help clients feel better faster.
We also highlighted reproductive health beyond just the immediate recovery, stressing that breastfeeding, while wonderful, is not a reliable form of contraception. Initiating conversations about family planning and ensuring clients have a method chosen before discharge is an essential nursing responsibility for every client.
And then there's that profound journey of psychosocial adaptation, understanding the subtle yet crucial differences between bonding, that initial pull, and attachment, the ongoing relationship, and being able to recognize and support clients as they move through those taking in, taking hold, and letting go phases while integrating their new identity as parents.
Critical, too, is emotional health. Being able to distinguish the very common transient baby blues from the more serious and debilitating perinatal mood and anxiety disorders. Knowing the red flags, screening routinely, and knowing when and how to escalate care to ensure the safety and well-being of both parent and infant is a non-negotiable part of your role.
And finally, the immense value of incorporating cultural care, understanding that every family's beliefs, values, and traditions profoundly shape their postpartum experience. Adapting our care plans with humility and respect to honor those traditions whenever possible builds trust, enhances communication, and promotes truly holistic, patient-centered healing.
The bottom line is this. Postpartum nursing care is truly a blend of sharp clinical vigilance, constantly watching for those danger signs with a critical thinking eye and compassionate, individualized support. It's about honoring comfort, culture, and complex family dynamics. By providing tailored education and genuine encouragement, you empower families to confidently embark on this challenging but rewarding new chapter.
So, as you step into your clinicals, your preceptorships, and eventually your practice as registered nurses, consider this. Beyond mastering the BUBBLE-HEE assessment, beyond knowing the medications and the warning signs, how will you, in your own unique way, ensure that every family you care for feels truly seen, heard, and supported in their unique postpartum journey? What's your approach going to be for bridging that essential clinical knowledge with profound human connection and compassionate care? We really hope this deep dive has equipped you with confidence and clarity for your nursing journey. Keep learning, keep asking questions, and keep making a difference in the lives of these new families. Thank you for joining us on the deep dive. Until next time, stay curious, stay informed, and keep making waves.